Welcome everyone to the Health Research from Home 10th webinar. My name is Will Dixon. I'm the lead investigator for Health Research from Home. I'm a professor of digital epidemiology at the University of Manchester, and I'm going to be co-hosting the webinar today with my colleagues Mark Elliott, who leads the SPRITE network, and also with Coral Stevenson, who's the project coordinator for Health Research from Home. The agenda for today, I'm going to start with some brief housekeeping, then we'll give you an introduction to Health Research from Home and to SPRITE. We're then going to have half an hour of talks from Danny Dresner and David Willis, followed by 10 minutes of question and answers. And then we're going to hear a little bit of event news from SPRITE. We're going to have a project update about linking patient-generated data to other data sources from Nathan Cheetham from King's, and then a final few announcements at the end. So let me just start with the housekeeping. We're recording today's webinar. The recording will be paused during the Q&A session, and then that recording will be uploaded to our YouTube channel next week. There's a link to the YouTube channel in the webinar that will follow, in the email that will follow the webinar. We really encourage you to submit questions. You can do that as the talks are going along, and then we'll come to the Q&A session at the end of the talks. Everyone's mic is muted for the presentation, but we can unmute people if you want to ask a question live in the Q&A section. And feel free to use the chat box to interact with one another through the course of the webinar. So I realise that we're bringing together two communities here, Health Research from Home and SPRITE. So to briefly introduce Health Research from Home to those from the SPRITE network, Health Research from Home is an MRC-funded partnership grant that aims to bring the community together to share best practice for using smartphones and wearables for population health research. The partnership is structured in this way that our purpose is ultimately to improve the lives of people living with long-term conditions, with a vision of making the UK a world-leading in large-scale, high-quality health research using smartphones and wearables, and specifically thinking about how we link that data to other national health data assets. And the mission is to build a collaborative community sharing know-how, skills, and knowledge to catalyse and enable future research. And a webinar is an example of how we're sharing that insight. So the programme, we have a whole series of events, the webinars being one, analysis challenges, grant writing retreats, and an annual event. We'll advertise the annual event at the end so you can get a date in the diary. We also have two driver projects that are learning how we link person-generated health data from these devices to NHS data. And you'll hear an update about the second of these two driver projects today, the long-term outcomes of COVID. Let me hand over to Mark to introduce the SPRITE network.
Hello there. Yes, SPRITE is the Security, Privacy, Identity, Trust Engagement Network Plus. So it covers the whole of what's called TIPS, which is a different order for the same acronym, Trust, Identity, Privacy and Security. So it's about joined up across those concepts, but also across disciplines and sectors. It's a very broad church. And we have a variety of different mechanisms. We both are a devolved funder. And you see the sandpit in the left-hand column there. But we also run events and commission events as well. So Innovation for you'll see in there as well. We run our own research. We have deep dive projects, sort of one-year projects that sit within the framework. So it's a whole cohort of different things and different ways of engaging with the community that are researching in TIPS. So yeah, they can go on to the next slide. I was going to just segue straight into introducing our speakers. So we have two speakers today, Danny Dresner, Professor of Cybersecurity at University of Manchester, and David Willis from Willis, I beg your pardon, David, from the National Health Service. I'm going to pass straight over to Danny, who can more ably introduce himself. So over to you, Danny.
Thanks, Mark. Fantastic. Okay, so we hope to give you a flavour of cybersecurity today. There's definite limitations to how much we can cover in the time available. So it's actually one of these situations where if it raises more questions than it answers and promotes a dialogue, then that's going to be great. So you'll be able to find us afterwards. There's my biography. I suppose if you can't find out much about me online, then you ought to think about your cybersecurity skills. My colleague here at the university always tells me that people like to see a statue of Alan Turing in these things. Keep the Alan Turing connection up there just to make sure that people know where we're coming. I'm really, really pleased to be doing this with my colleague Dave, who is traditionally on mute.
Oh, traditionally on mute. Thank you, Daniel. So yeah, I'm David Willis. I'm 30 years cyber specialist. So I've been involved with computers and digital since the late 70s. My starting machine was a teletype terminal that punched out paper tape. I've been working in the NHS in strategic leadership role since about 2019. But actually, when I was a teenager, I sat on the dark side. And if anybody wants to have a look at Prestel and the magic numbers that you've got on the screen there, you get an idea of the challenges that we still haven't overcome. The teenagers that do things to our systems simply because they can do. Back to you, Danny.
Thanks. Perhaps I should have explained this at the beginning. Throughout the main part of this presentation, you'll see a couple of little icons, top left and right. I don't know whether we'll ever be described as icons, but there you go. Where Dave and I are going to explain and share some of the cybersecurity stories relevant, I hope, to the interests of the great community that we've got the privilege to actually talking to. So we're going to talk about cyber, put some context to it and give some examples, talk about this all-important data, the threats, but importantly, also what we can do to make things more secure, to give us the trust and confidence to make sure that we can make some improvements and move things forward. So over to Dave. Iconography at work.
So what is cybersecurity? And this is the $1,000,000 question. Everybody hears the word cyber and everybody kind of goes, oh, what is it? And it's kind of simple. It's the art of protecting networks, devices and data from unauthorized access, from criminal use, and the big and here is it's the practice of ensuring confidentiality, which you're probably already aware of, integrity, which we'll cover later on, and availability of the information that you need to do your job. Next slide, Daniel. So this is a slide I did many years ago whilst I worked at head of information governance for a trust. So the trust talked a lot in the terms of confidentiality. So this was incident information that we had for just over a month. I went through the incident reporting system, and anything that was related to information, I took out and I did a deep dive on. And we had 14 confidentiality incidents in that time frame. And as you'll see from the impact on the individual, not a great deal of impact on the individual. But when it comes to the integrity or accuracy of information, or the availability of information from the perspective of patient care, it's where we start seeing harm, but we also start to see the scale of the problem, where accuracy of information and maybe the information that you're working with becomes a real challenge. And the discussion that I tried to start at the time with my board was, this costs you money as well, because you have to pay to fix these problems. Next slide, Danny. So where does all our health data come from? Now, we've been talking about wearables and mobile devices, but actually in the NHS, it comes from all sorts of different types of equipment, including patient wearables, including kit that might be attached to the patient at a bedside. And it includes stuff that staff type into the system. Next slide, Danny.
And I think what some people might find surprising is the value that criminals can find about this. So there's always the side of general mischief, and also opportunities for causing general harm because you don't like the country or you just want to make your name into the news. There was also one case where a hospital computer system ended up being attacked by accident. The hackers apologized and tried to put things right. But on the whole, medical information, does has high value. If you look at that table there, you can see that the classic stolen items that we all worry about, such as our bank account details and passports and all of those other areas, are actually bargain basement stuff for the criminals. And the effort they put in for the medical records, from the point of view of their business model, pays off. What is more difficult for us, of course, is to be able to put a cost against that for our research, and even more difficulty to be able to cost the reputational issues. And that, of course, leads to the longer term possibilities of trust and engagement and research before we even get to the opportunities for treatment.
So the digital hospital is changing. On screen here, you can see the types of digital equipment that is directly recording information into the patient record. And this stuff will become more common as time goes on. But the other thing that we need to remember is, of course, the new NHS 10-year plan is talking about moving patients out of the hospital into their own homes. And some, not all of this kit, but some of this kit and the wearables will follow the patient to their home. Now, generally, our hospitals are fairly secure areas when it comes to digital. We do have our fair share of incidents, but they are fairly secure. Stuff like this is monitored, stuff like this is maintained. What happens to it when it goes into the patient's home? I haven't got an answer to that question. But if you're then relying on that equipment to give you information that you need for your research project, how accurate is that information? How available is that information going to be? Daniel, next slide.
So don't expect you all to come out of this as cybersecurity experts. I'm not even sure what that moniker actually means, but I think it's useful to have an appreciation of the different components and even what I might call the process that goes on behind this or essentially the bad activity that we need to be able to counter. We've got things that we value, the important assets, which might be physical assets, it might be the data, it might be the intellectual property, the things which are important to us. And as you would have seen from that earlier costing, there's quite a motivation for people to be able to get access to it and to use it for nefarious means. However, it does depend on capability. So before we rush into putting into lots of controls and blocks and things which actually might damage our access and our patients' access to computable information and data, we need to really consider the capability of people and whether they can actually do things. Unfortunately, of course, much of the technology, I always say that all software is broken. If we're really lucky, we'll have moved on to the next version before the vulnerabilities are either discovered or either exploited. Because if you test software, you might find a load of vulnerabilities, but in practical terms, whether somebody can actually exploit that vulnerability is another matter. So there's a sliding scale that you really need to pay attention to. And when it comes down to it, whether somebody can actually get access and do something with the data, whether that's necessarily important, all comes down to the actual impact it will have on our patients and our research as it stands at the moment, and for future opportunities as well. I mean, that does that little sort of cartoon of children being upset at the loss of their biscuits does translate into into the real issues of the data and the information and the assets, and we need to think about the physical care that we take and the precautions. Again, it does come down to capability. So it actually might require, for example, physical access to a device. But never underestimate people's ingenuity for that kind of thing. Just from a hospital context, there was a case where it was found that certain night staff were misappropriating various monitors for viewing things like Netflix and the like, when they should have been taking more care of the patients. So they thought if they used devices without screens, that would get over the problem. And of course, all that happened was that the staff brought in their own screens as well. But the important thing is looking at the opportunities to remove and reduce the loss, or at least to be able to make it less likely. So it's very important to have ways of detecting the anomalies when bad stuff is actually going on, ways of disrupting. Back in the day when I started, it was all a matter of stopping bad things happening. Now we still have to do that kind of thing, but also recognizing that there will be times when people will get onto our networks and we must be able to disrupt their activities. So we can't always deny them access, but we should. At the same time, we need to make sure that the people we want to have access can get access in the most easy and efficient way. We don't want to put them off by difficulties. We might be used to the kit. The people who are taking part in our research and the people receiving treatment may well not be so savvy, may not be so literate in those areas. One area which I think is which is worthy of study is looking how we can devalue that data. People reduce the motivation for our opponents and adversaries to actually go out of it in the first place, and to be able to counter the devices and the hardware and software that they use. One of the upcoming and developing areas is going back to the kind of things that became famous during the Second World War, in terms of what people were doing and what's actually going on to actually deceive people, so they're not actually attacking the live system, which of course for the forensics people is a great way to learn what adversaries are doing, so that future systems can be improved, or even the existing systems can be improved, and the attacks headed off at the pass, or at the very least be able to degrade them so that they do less damage.
So what is the volume of data that's out there at the moment? So I pulled this off the internet. It's a great place to get ideas of the volumes of data and the growing volumes of data that are occurring on the internet year by year. And we're not talking about megabytes or terabytes or petabytes. We're talking in zettabytes. And if you have a look at the graph, it's growing every single year. So what's the cost to you? Well, as part of your research project, have you got confidence that you can trust your data? That's the first question you need to ask. What happens if that data vanishes? So if you've been running a web-based system as a distributed denial service, or if you've got it stored on an endpoint and it's encrypted, can you still do your job if that particular bucket of data has gone? If you get an email through and it's something along the lines of Pfizer are wanting to employ researchers, and it looks really promising, and you've checked it all out, and you phone the number they give you, and it all sounds promising, and they offer to send you through the forms to fill in so you can apply for the job. It's actually happened. to a number of clinical research organisations during COVID. And those application forms that dropped through for the staff to fill in were full of malware, and their research data was stolen. And what will others think if it all goes wrong? What will others think if their data goes walkies? But before you get too scared, if you think you're having a bad day, right now there's somebody in Whitehall who recently cost the UK £7 billion and put 100,000 Afghan lives at risk by pressing send on the wrong document. You need to look after yourself. You need to look after the data that is in your keep. Daniel, next slide. So what do? Well, the first thing is, don't panic. It's a lovely flashing logo from a Douglas Adams book, but it's well worth it. You're not on your own whilst this is happening. You may not understand the technicalities of the stuff that Daniel's talking about, but honestly, there will be people somewhere within your organization that do understand this. And at the end of the day, cyber is a team sport. All of us need to work together to make this work. We're only as strong as our weakest link. And of course, just because you think everybody's out to get you doesn't mean to say that they aren't. There is such a thing as a healthy tinfoil helmet. Daniel, next slide, please.
So just at that point where I kind of hoped, or we'd sort of hoped not to fill you with what is generally termed as FUD, the fear, uncertainty and doubt, we did kind of dip into a little bit of it, because this is, this is serious stuff. Lives are put at risk. Bad things will happen. But of course, the most important thing is looking at to see what we can do to increase the risk of success. Traditionally, security has been a discipline of saying no to things and putting things and blockers in the way to stop the bad people. But unfortunately, they've quite often made things life difficult for us and the other good people too. So there has been a general change, firstly looking at how we cope when bad things happen, but importantly, and this is a piece of research I'd commend you to have a look at, particularly because we're dealing with people in their own homes, in their own environments, without an understanding of the technology that they will be given to use, and a limited understanding of what it is that they're providing with that technology and how that will be used. The important thing as well is to remove the barriers to security. Perhaps one of the most important, or one of the easiest things, is understanding the actual cost, so that we might be, because of our lifestyles, be used to fairly good internet access. We have to remember that this is not the case. An immediate personal lesson that I learned in COVID days. I assumed, working in a department of computer science, all of my students had long since acquired their own laptops or their own computing devices at home. This was not the case. The reason why many students were in the building 24/7, or at least till midnight when they locked it up, was because they didn't have access to this kind of kit, which also burst a bubble, because I just thought they were being particularly keen. So removing barriers is just as important to the actual components that you can think of or design into the way that the research is done, the way that the systems are built to support that. And there are at least two ways to look at this. The first one, the one on the left, is a little bit of a play on words. Risk originally originated from the idea of sailors sailing off into the unknown, which is why maps would have a "Here Be Dragons" section, because that's where the cartographer didn't know what was there and didn't really want to admit as to what was or what might be in a particular part of the sea, and didn't want the sailors to go there. So working on the basis that cybersecurity is a risk management exercise, then the research that I've been engaged in has looked at defining sailing the seven seas. Okay, perhaps 3 meetings to decide the name of the project maybe wasn't worth it. No, that was a joke as well. But those 7 C's are how you get the balance between the people and technology. We often talk about people, technology, process, but when it comes down to a patient and an engagement, then the core moment of interest, the more core moment of focus is how that patient is actually interacting with the technology, so that the technology will deliver the data that's actually required. One of the things that I think has been a long known lesson in security in general, but still has to be filtered through and absorbed properly, I think, into cybersecurity, is the idea of maintaining layers. And this is a good thing as well, because when you break things down into layers, you've got the opportunity to see where the best security tools, and I don't necessarily mean things that you buy and pay expensive software licenses for, can actually be placed to make sure that the burden of responsibility ends up on the right people, rather than, for example, the patient at the end of the chain. One of the biggest differences you can make is to look at what I call the Cyber 5 a day. The National Cybersecurity Centre recognises the complexity and the difficulty of keeping everything secure, but recognises also that there are 5 things that you can do. I don't think time will allow us to go through them in any detail, but these are the generally 5 controls which can deflect 80% of the low-level automated attacks that come from the internet. Now, of course, it still leaves you with a significant amount of work to do to keep things safe, but it's a little bit like having a garden wall. Most people will walk around it, so you only have to deal with the cheeky so-and-sos who will actually climb over it. So from here, I hope that you'll have picked up a few alarms from David and I, but at the same time also realize that for each alarm there is action that you can take. There are things that you can do. Sometimes it will mean drilling down to a particular problem. You will miss something, but the important thing, and this goes back to the whole definition of the word cyber, which really comes from governance and steering things in the right direction, is that you learn and you go back and you adapt, which is why testing and the collaboration and the cooperation and not making assumptions of all of those people who we need to work with to gather this data, analyze this data, and do good things with it, that we understand their worldviews, understand the art of the possible, and they understand the art of our requirements, so that things will develop and improve. So I'm not saying it's an easy to understand area, but the good news is that with a little understanding can actually go a long way. David, I don't know whether there's anything you'd like to add?
So I think Danny's slide says things really nicely. And I think the one I would emphasize is that don't panic about this. Honestly, it may be a bit intimidating if you approach the techies within whatever organization you work in. But if you tell them, you've been talking to Danny, or you've heard the presentation from us, and you're trying to do a research project of whatever it may be, what do they think about it? They may be busy and push you away first time, but honestly, they will want to help you. Nobody wants to see this stuff go wrong. It's too harmful to us all. Team working is fundamental on this, and being better informed and working together is a key to making this stuff work. Daniel? Thanks
for your attention. I think I'll finish with Talking about monitoring earlier on, the old MI5 logo or motto used to be that security is the reward for never ceasing vigilance. Of course, we need to be vigilant. At the same time, we need to do our day-to-day work. So that is a bit of a challenge. So I think as long as we stay alert but not alarmed, we can get the balance right. Thank you for listening.
Brilliant. Thank you very much, Danny and David. So no doubt that was educational for everyone. Unfortunately, we have to move on now. So I think it's now for me to very briefly tell you a little bit about Sprite's up and coming events. So I think we'll share the screen again.
Oops.
Oh, there we go. As you can see, we've got quite a lot going on. It's a continuous treadmill of stuff from our point of view. We have our own webinar series called Lunch and Learn. These run a third Wednesday of the month. Have I got that right? Thank you very much, Courtney. And the next one is Emily Collins on Where is Trust? Human Implications for Interactions of Trustworthy Robotics and AI, which is on the 17th of September. So there are links to all these from on our website if you want to find out more. We have one of our innovation fora on the 25th of September, AI and policing in conjunction with N8PRP. And then a hackathon on identity policy, so policies of identity systems in conjunction with Chatham House. That's going on starting next week over 3 sessions. We have member-led events, so we have a membership. I didn't mention that earlier on. We've currently got 1,200 members in our network, and members can propose events and then organise them in various locations across the UK or online. And this one's on AI and journalism happening, tomorrow. That's got a very busy schedule this week. And then we also have a citizen engagement workshop on tips in digital citizen connected places, also known as smart cities. So that's one of our deep dives. And we've got a citizen engagement workshop. We have other workshops running out of that, various expert workshops and other stakeholders. If that's something you're interested in, get in touch with us and we can hook you in the right way. And then, it's me. I'm giving a talk at the International Cyber Expo, also called ICE, on anonymization. Is it dead? Very, very key topic in March. So I think that's our September activities. There will be more in October and November. Just visit our website if you're interested. You can join and then you'll receive a monthly newsletter telling you what's going on in the immediate period afterwards. So you can keep in touch. Thank you.
That's wonderful. An impressive set of events. Thanks, Mark. And thank you very much, Danny. Thanks, Dave, for the presentations. I'm going to hand over to Nathan Cheetham now, a senior postdoctoral data scientist at King's, to tell us about how they're progressing with their driver project of linking data from the COVID Zoe symptom study to electronic health records. So thanks very much, Nathan. Over to you.
Thanks, Will. Share my screen. Thanks. Yeah, so I'll be talking about the second driver project as part of Health Research from Home, which is looking at trying to understand the long-term health effects of long COVID. To give a bit of a recap about why we think this is important, long COVID has affected millions of people across the UK and internationally. And the latest kind of national estimates are about 1.5 years old now, but back then the estimate was there was still over 1.5 million people who were living with symptoms after having COVID that were affecting their daily life. And so, as well as this data, there's kind of still stories or more like anecdotal data about how people are still living with long COVID. And we want to understand what are these long-term health effects of long COVID? How is it affecting people's health now, 5.5 years since the start of the COVID-19 pandemic. And how we're doing this is using our study data. So I'm here representing the COVID symptom study biobank, which is a health study that started in 2020 with the aim of trying to understand long COVID in detail. And in this project, we're linking our study data with electronic healthcare record data, NHS data, from using the platform, the UK Longitudinal Linkage Collaboration, which is a platform that allows us to link these different data sets together and do analysis for research purposes. And in today's talk, I'm going to be talking about this data in more detail and our plans for analysis, as we are still kind of going through this process of joining the platform and being able to link the data, which I covered in previous updates I've given to at this webinar. So within this project, we're working with three different sets of data, three different data sources. The first data source is data that comes from the COVID symptom study app, which is where our participants were recruited from originally. And this was an app which started at the beginning of the COVID pandemic as a way to monitor symptoms on a daily basis. People could log in and say how they were feeling on a given day. And then that was used to try to estimate how prevalent COVID was at the time. But it means that we have detailed time series information about people's symptoms in and around before and after they had a COVID test, whether or not that test was positive or not. And then we've also have our own study data, which has got where we've done several different surveys as well as other data collections after people have been recruited into the biobank. And we're now going to link both of those with NHS data through the UK Longitudinal Linkage Collaboration. And in combination, these three different data sets give us longitudinal information, so we can have information that goes from before the pandemic, based on the survey data that we've collected about people's circumstances before the pandemic started, including their health. Then we have detailed symptom tracking information from what people recorded in the COVID symptom study app. And now we want to link those two and see how it relates to the longer term outcomes for health that people have been experiencing through the NHS data and through our survey data as well, where we've also collected information about health. So broadly, we want to do two types of analysis. We want to firstly describe in detail the types and the frequency of different health outcomes for people who have had or are still living with long COVID. And then we want to compare the likelihood of different outcomes for people with different histories of COVID-19. So comparing people who have had long COVID to people who've never had COVID or had relatively short or mild case of COVID. And we're looking to kind of create a risk trajectory, such as these figures here, which are from other papers that have done something similar, looking at neurological and psychiatric outcomes for people with COVID versus other respiratory infections. And we're going to try and do something similar to that using the healthcare record data to look at various outcomes. So in terms of what actually we want to look at, within the UK LLC, on the right hand side this is like the long list of all the different NHS data sets that are available within the platform, and it covers all different types of healthcare activity, from hospitals to GPs, and then more specialist areas such as the cancer register. So in our analysis, we want to focus on diagnoses of new health conditions following COVID-19. We want to look at any emergency or unplanned care within the hospital setting. such as looking at the A&E data sets and the admitted patient care data sets, as well as other planned care or use of healthcare services, like going in for clinic visits and other treatments. And then we also have the mortality data set, which we may look at depending on the numbers, the sample size in there. And then we also have some overlap with our own study data in our surveys. So we've also collected information about health conditions that have been new or newly diagnosed or onset after the start of the pandemic. But we also have more detailed information on symptoms. So we've asked people to fill in validated questionnaires on things like fatigue, mental health symptoms, and the extent to which their health is affecting their day-to-day lives or ability to function on a daily basis. And we are going to basically compare groups of our participants based on their COVID-19 history. And we can combine the different data sources that we have to group people based on whether or not they've had a SARS-CoV-2 infection or COVID-19 illness, and the duration for which they've had symptoms. And then look at how the risk of the different outcomes that we look at are related to that COVID history. We also have more detailed prevalence of almost 30 different symptoms from the app reporting, and things like whether people still feel like they are having symptoms which are being recorded in surveys, and whether they've been diagnosed with long COVID by a doctor. And that's another thing that we want to look at in the kind of secondary analysis while we have access to this linked data, is what is the similarity or concordance in the diagnosis of long COVID. So we have survey data where quite a lot of people have told us we have a diagnosis from a doctor of long COVID, and we want to see does that match with what we see in people's electronic healthcare records? Because of research that's been done to date, which has shown that long COVID has generally been very limited in how it's been, in the frequency with which it's been coded. It's a lot less than the prevalence estimates for the population. So that's another thing we want to look at, and will hopefully show the value in using this remote patient reported or participant reported data. And that's it for me. That's where we're up to now. Thanks.
That's great. Thanks, Nathan. It'll be fascinating to see the results of this once the linkage happens. We're sort of beyond 18 months into the 3-year program, and it's interesting how long the setup of these projects takes, isn't it? The linkage sounds like it's the easy thing to do. You just press the button, but actually there's a lot of hard work that goes into it, including things like understanding the risks of joining together data sets relevant to today's talk. So thanks very much, Nathan. I'm just going to finish off with a couple of final things to share of announcements. We had our first annual event for Health Research from Home in February of this year, and we've now fixed the date for the forthcoming annual event. There's space for 120 people. We hope that you can save the date for the 13th of February next year. There'll be the same number of places. Register your interest, and we're keen to hear from you if you'd like to come along. The next webinar is in 2 months' time, in November. That will be about how we use smartphones and wearables to measure sleep. Something that is difficult to measure in the best possible way. It's bringing people into a lab and attaching electrodes to their heads. It's something that's difficult to self-report from home, because how aware are you of how well you slept? It's quite limited information and subject to recall. But being able to use consumer health data to measure sleep is an increasing area of interest. And we've got two really excellent experts about that, Matt Jones and Lorna Caddick, to come and talk to us. So please sign up for that now. All of the webinars from the webinar series are available on the Health Research from Home YouTube channel that you should be able to find fairly easily on YouTube. And we'll just end with links here in case you wish to access some of the other resources from Health Research from Home. So thank you very much indeed again to the two speakers, Danny and to Dave, to Mark for co-chairing, to Nathan for sharing the updates. Thank you all for coming along, and we look forward to seeing you next time. Thanks very much indeed.